We're going to start with Chapter 10, Airway Management. So let's talk about how we're going to recognize adequate breathing. So in order to understand what difficulty breathing is, we have to understand what adequate breathing is. So we're looking at breaths, as we've said, between 12 and 20 times per minute. So this is in an adult. Your kid and your infant are going to have higher respirations that are considered regular. A regular pattern of breathing in and breathing out. Short breathing in, longer breathing out. Take your breath and you'll feel it. Clear and equal lung sounds. As we talked about last week, noisy breathing is not normal breathing. Regular and equal chest rise and fall, and appropriate tidal volume. The depth of respirations needs to be appropriate as well. Okay, so now that you know what normal breathing looks like, basically anything that isn't normal breathing is abnormal. Noisy respirations, irregular respirations, shallow respirations, patients breathing fewer than 12 times per minute, patients breathing greater than 20 times per minute. But keep in mind, this is going to be based on what they just did, on what they're still doing, on whether or not they're physically active, also looking at, are they showing signs and symptoms associated with it? Do they have cyanosis and blue lips? You're going to have increased effort of breathing, those accessory muscle use, skin color that is, it just doesn't seem right, ashen, cyanotic, sweating. All of those are signs of abnormal breathing. When you come across this during your primary assessment, you need to treat it. You don't bypass a patient. You don't not give oxygen to this patient just to move on to the circulatory check. A patient can appear to be breathing even if their heart is stopped. Remember that the expiration, your exhalation, is a passive process. You've got patients who will have irregular patterns of breathing, taking breaths in and out with no actual regularity. This can happen when there's been a serious head injury because, as I told you, the brain helps you understand when to breathe and how to breathe. You've got Kussmaul respiration. So this is patients who are in a diabetic emergency, who have some sort of metabolic crisis. Deep, rapid respiration. Long in, short out, quickly. Again, anything wrong with the B, with the breathing, is going to be a high priority. And remember, even though the patient may be breathing in and out, that doesn't mean that they're moving the oxygen around in their body. And that's where level of consciousness and skin color come into play. If they're not getting oxygen into their cells, they're going to have that brain damage. They're going to show that altered level of consciousness. You're going to get the cyanosis of the skin. You also need to look at whether you want to take pulse oximetry. Remember, your pulse ox can show you the level of oxygenation on the blood. Basically, it sends a little laser beam in, and if you consider your red blood cells are the taxi cab of the bloodstream, it's trying to figure out how many taxis are full. So we like to see somewhere between 96 and 98%. But we don't use that as an indicator as to whether or not we're going to give oxygen. We use signs and symptoms, altered level of consciousness, cyanosis of the skin, all of that to make the decision. The number just gives us another piece to that puzzle. So remember that airway comes first. Well, airway comes after scene size up and scene safety and all that stuff. But remember that when you finally get into patient assessment, the first thing you do is airway. And that's why we need to start with an open airway, because you cannot breathe if the airway isn't open. So we've got to position our patient correctly to be able to assess the airway. Face down, not correctly. If they're unconscious or semi-conscious, laying on their back is going to be the best position. You have to consider that you've got to open the airway potentially with the jaw thrust or a head tilt chin lift. Remember, jaw thrust is what you use for your trauma patients. And once the airway's open, so beyond the tongue, we do have a lot of other structures that can cause issues with blocking the airway. So dentures. You come to a patient who's unconscious and you open the airway and the dentures are loose or falling out, take them out. They're not going to be able to get put back in and we're not wasting our time. But think about the oral airway. Isn't it nice to have the teeth for the oral airway to actually sit against once it is fully inserted? And when we don't have the teeth, it makes it a little harder to get a seal. But obviously, if the dentures are falling out, we don't want them blocking the airway. You might be suctioning blood, vomit, mucus, frothy sputum. Maybe they were eating steak before they passed out, so you have to remove foreign bodies. These are the things we need to consider, and we will talk about foreign body airway obstruction later on in this chapter. So, to open the airway in your non-traumatic patient, non-trauma opening of the airway, we're going to use the head tilt chin lift. So it literally is a head tilt and a chin lift. Remember, we want the head to be in line with the rest of the body in a neutral position. Head tilt, chin lift is non-trauma. You're going to use the heel of your hand on the forehead, apply pressure, and then lift the jaw with 2 fingers upward. Head tilt, chin lift, non-trauma. Have I said that enough? Your trauma patient gets a jaw thrust. Basically what you're going to do is you're going to come behind the patient and you're going to put don't put their thumbs, put your thumbs on their cheekbones. Put your first 2 fingers at the square of their jaw and you're going to push up. This is just like you did it in CPR. And I'll put some videos up so that you guys can see what it's going to look like. Your goal is to move the tongue off the back of the throat. Again, once you've opened the airway, you need to hold it open unless you're going to put an adjunct in it. And you need to look, listen, and feel, looking for equal rise and fall of the chest. If there's a foreign body airway obstruction, then obviously it's not going to be there. The book teaches the cross finger technique. You can go in, you can look at it. Here's my problem. I don't want to put my fingers into my patient's mouth. I don't want to cross that plane because if they become conscious or seize or do something that causes them to close their jaw on my fingers, I've now been bit by my patient, and that is the last thing I want to do. Here is the pictures of your jaw thrust. Notice they're actually using their thumbs to push the jaw down while they use their first fingers to push the jaw up. This is good. So, as I said, once you've opened it, this may be where suction comes in. So suction is going to keep the airway clear. We've got portable suction, hand suction, fixed equipment suction. That middle picture is showing you suction that's in the ambulance. The one on the right in the red bag, that's what you normally see. Another picture that those of you who have had kids or siblings, the bulb suction, that little blue bulb that's used to suck out an infant's nasal passages. It's another hand-operated piece of suction. When you go into patients who are having difficulty breathing, when you go and treat patients who are semi-conscious, consider taking the suction unit with you in case you need it. You don't have to wait for it. So you've got a portable or fixed unit, and this is going to have a disposable collection bottle where all of the secretions and suction will go. When you suction your patient, you should probably take that into the hospital, A, because it's a biohazard, and B, if this is the result of some sort of an overdose, having access to what they took is important. You're going to have non-rigid catheters. They're going to be thicker, a wider opening to take a thicker substance. I mean, we're not vacuuming out of their airway. We're not going to be able to pull the stake with the suction unit, but we should be able to get some thicker sputum, thicker vomit secretions if necessary. You need to make sure that you inspect it regularly. Understand if it works. The last place you want to find any equipment fail is in the field. You want to test the pressure. You want to make sure that you have the appropriate catheter for the tubing. You never, ever, ever suction greater than 15 seconds or 10 seconds for the child. So 15 seconds or less for an adult, 10 seconds or less for a child, and 5 seconds or less for an infant. Never more than that. Because while you're also suctioning vomit and blood, you will get the oxygen that will be coming into the suction unit as well. So when you are suctioning, they are not getting oxygen, and you can lead to hypoxia if you suction for too long. And you should suction coming out. So you want to insert your suction catheter to the back of the throat, no further than you shouldn't, the suction catheter shouldn't disappear, and then start suction on your way out, counting 1 Mississippi, 2 Mississippi, 3 Mississippi. You don't have to go to 15. If you're done at 4 Mississippis, then be done. And once you've suctioned, then you need to oxygenate your patient again. When you have things that can't be suctioned, like large chunks of food, thick secretions, you want to roll them to their side so that they don't aspirate it into their lungs. And then you want to use your gloved finger. This is about the only time I want to put my finger in the mouth to clear it out. This may be a tooth, it may be steak, and remember, just like in CPR and foreign body airway obstruction, you want to do a finger sweep. You want to suction for 15 seconds, less in children, and then ventilate, and then suction, and then ventilate. And like we said, if you have to continue suctioning and you never get beyond your ABCs, then you never get beyond your ABCs. So you suction for 15 seconds or less in your adult, you bag them for 2 minutes, you suction again. Don't wait on scene. This is a breathing problem. This is an airway problem. This is a load and go situation. So now that you've opened the airway and suctioned the airway, we want to put an airway adjunct in. You don't put these in until the airway is clear, because otherwise you're just going to be pushing all of that junk, all of the fluid and vomit and stuff back into the airway. So with that in mind, we're going to look at first the oropharyngeal airway. Dear Lord, don't ever call it that after this class. It's an oral airway. It's going to go into the mouth. This is going to be used to keep the tongue off the back of the airway, and it's actually going to give you a path to suction if you still need to. So who gets an oral airway? All unresponsive patients who do not gag. Because if they gag, they are still to a point protecting their airway. So every unresponsive patient without a gag reflex, and easier said than done, apneic patients that are being ventilated with a bag valve mask. So who doesn't get it? Well, let's see if a conscious patient lets you put an oral airway in. And if you don't want to see vomit, I wouldn't put one in a patient with a gag reflex. Nasal airways are going to be given to those who do have a gag reflex, but maybe who are semi-conscious or not fully protecting their airway. They're unresponsive, they have an altered LOC, diabetic patients. I put oral and nasal airways in patients if we knew that they may vomit. That way we've got a protected airway through the nasal passage. It really just depends. Just because you have an oral in doesn't mean you can't put a nasal. If they don't tolerate an oral airway, and in reality, if they're unconscious and unresponsive, they should tolerate it just fine. But maybe they've got a mouth structure that doesn't support it. Maybe you took those dentures out, and now the oral airway isn't staying in. Who doesn't get it? Anyone who has a head injury and is bleeding from their nose. No one with a head injury, even if they're semi-conscious, should get a nasal airway. Reason being, we don't want to block the blood flow, because this is what's keeping the pressure off the brain. And if they've had a fractured nasal bone, it probably won't actually. Another way to maintain the airway is the recovery position. So if they're not injured, they're breathing on their own. You've learned this in CPR. You roll them to their side. You prop that leg up, because if you don't prop the leg up, they're going to end up on their face, and then you have an airway problem. So again, that picture of the recovery position is not appropriate for patients who have spinal injuries.